First of all, thanks for having me. Really excited to be here. As a way of background, I'm an assistant professor down here at the University of Utah, but probably more important, I grew up in Boise and spent my whole childhood up till college in Idaho, and then had the blessing of going to the University of Washington for medical school. Spent some time in most of the clinical sites in Idaho in training, and then went down for advanced training and residency and fellowship at the University of Texas Southwestern in Dallas, and very happy to be back. And really kind of taking care of a coronary care a type of population. I'm the cardiovascular director of the Idaho amyloidosis program, as well as a heart failure and transplant specialist here. But, I really come back to the time that I spent in these, smaller places, smaller towns. I actually spent some time in Orofino over the summer in Aruap. And I really kind of think of those cases and those people, every day as I'm doing kind of the more advanced care. So while it's coronary, it really speaks to kind of the relationship between the two and what we can gain. So I really appreciate all of your effort for all of our medical students overall. From a disclosure standpoint, these are related to my work in amyloidosis with a couple of the companies, not related to what we're talking about today. So we'll talk about diagnosis of heart failure, a schema, really how to think about it, how do we talk about these things in our notes, and we'll have a short foray into treatment, but that'll be held kind of at a separate session in a more kind of detailed organization. So first of all, how important is this issue? Is this really something that warrants attention? The lifetime risk of heart failure is 1 in 4 people. HF Stats, which is an awesome publication, just put out last week, actually, for 2025, gives a lot of these slide decks, which are excellent. When you look at the numbers in the United States, in 2020, 6.7 million people, and that's expected to increase to 8.5 and up to 11 in 2050. So a huge issue, a huge burden. Economically, it's a big burden as well. When we look at the male-female predominance, we see at a young age, it's relatively similar. It becomes more male in middle age. But interestingly, our female population at older ages, particularly heart failure with preserved ejection fraction, which we'll talk about, we see a predominance. So really across the spectrum, and a significant increase with age. And so our geriatric population is a large heart failure population. So really, at the end of the day, heart failure is a clinical syndrome. And, when you think about it, oftentimes people are like, of course they have heart failure. I know it when I see it, when they come into clinic or in the hospital, et cetera. So when you're actually defining it, it's a little bit challenging. Here was the 2011, I'll call it an attempt to define heart failure. I don't know about you guys, but I fall asleep about halfway through this statement, this very large statement that's pretty difficult to digest. So from our perspective and from a heart failure specialist perspective, we really tried to make this a little bit more simple in 2021 with the universal definition of heart failure, relying more on graphics and thoughts as opposed to those long word-based definitions. So really, I think this is one of the take-homes, which is, what is heart failure? It's symptoms or signs of heart failure caused by something going on in the heart, corroborated by elevated natriuretic peptides, or objective evidence of volume overload, cardiogenic pulmonary edema, systemic congestion, again, caused by a cardiac issue. So really taking that pretty complex issue and putting it into a simple slide and in a simple kind of understanding. So what are those symptoms? Dyspnea on exertion, orthopnea, bendopnea, swelling in the extremities, PND, those things that we talk about in schooling, for patients with congestive heart failure. So our typical symptoms. Signs: third heart sound, elevated JVP, displaced PMI. If you guys are into POCUS, thinking of UJVP, thinking of IVC, thinking of VEXUS in the kind of more complicated standpoint. And then the less common, but oftentimes more specific, are significant edema, RALs from pulmonary edema, pleural effusions, being more tachycardic, having less urine output. And then as we get to the more advanced heart failure people, narrow pulse pressure, which suggests a low stroke volume and low cardiac output, and then cold extremities, which is a similar type of a phenotype. Coming from the University of Washington in training, we talked a lot about how do we take these physical exams, signs, and symptoms, and how do we relate them into what's actually happening. So I really love this book from Dr. McGee, who I think we all look up to. And it's saying, what is the likelihood ratio of these different things telling us that somebody, in this case, has elevated left heart filling pressures? So I go back to this book all the time when I'm teaching, medical students and residents across the spectrum of disease processes. But specific for heart failure, we see elevated left atrial pressure or left-sided heart pressures. If you're tachycardic, if you have an abnormal Valsalva response, are very specific findings that have a high likelihood ratio, meaning if they're present, they're very likely to suggest elevated left atrial filling pressures. And we see some of the negatives as well. So here on the right is kind of the combination or the totality of these. And so we see if you have an elevated JVP, yeah, it certainly takes your pretest probability and increases your post-test probability, but not as strongly as your hepatojugular reflex or a displaced apical impulse. So coming back to this, coming back to, what are the sensitivity and specificity of the physical exam findings, I think is a helpful way to teach and to think about when you're seeing somebody in clinic. Do they actually have those symptoms? Are they related to elevated left atrial pressures? How about BNP? So when we think about BNP or NT-proBNP, we think about different levels in the ambulatory setting, in the emergency room, and really how that helps us overarchingly. And really how I view a natriuretic peptide is a negative predictive value. And so if a patient has a BNP that's normal, the likelihood that they're in decompensated heart failure is the problem for their shortness of breath, is unlikely. So a very low likelihood ratio if you have a normal NT-proBNP. How about the opposite? Is it diagnostic? Well, specificity is lacking. Many things can cause an elevated NT-proBNP, pulmonary embolism, pulmonary hypertension, ARDS, renal dysfunction, etc. And so if I have somebody in the emergency room, they're complaining of shortness of breath, and the ER calls me and say, hey, I think it's heart failure, and they have an NT-pro that's normal, it's pretty unlikely that they have the correct diagnosis. If they call me and NT-pro is 1500, you still need to think about that other differential, that's kind of a short list here for what's going on. So that's how I conceptualize things overarchingly is, okay, are they having those signs and symptoms of heart failure? Do they have an underlying cardiac issue? And we'll get into some of that testing in a minute here. And then corroborated by one of these exam findings or elevated natriuretic peptides that make sense in the context of how good is the test that you're doing, both a biomarker standpoint as well as the physical exam. So how really good quality of a test is it as a whole? Before we talk some of the diagnostic testing, I just want to tell you kind of about how as a field we're moving to think about heart failure as a whole. We've moved to this staged symptom, and this is a way of describing it. And this really is for research, but also kind of a different way of thinking. So a stage 1 patient is somebody who's at risk. We know diabetes, hypertension carry high risk of heart failure for those patients, like we started in their 80s with HFpEF, for example. So if somebody has those comorbidities, they're at risk for it. So how can we modulate or decrease that risk over the long term? Somebody has pre-heart failure is moving along that spectrum. And then 3 is that classic congestive heart failure patients that we talked about. And 4 is advanced heart failure, and particularly with symptoms at rest. To describe those symptoms, now we're talking about that group 3 and 4. We're still using the NYHA classification with all of its pros and cons. So 1, really no symptoms, 2, mild symptoms, 3, moderate symptoms, and 4, severe. So when we're having a conversation from a referring provider, we'll get to how we kind of have the same conversation using the same, words and tools, so everyone understands what's really happening as opposed to a little bit of the vagaries that can happen. Really key point, heart failure is a clinical diagnosis supported by physical exam and laboratory work. When we're thinking about how to work up heart failure initially, we really need to say, what is actually causing heart failure? In female and male populations, it's slightly different. So here's a nice wheel. So a lot of information on the slide. So let's unpack it. In purple, we have reduced ejection fraction. We'll talk about the echo in a second. In orange, we have mid-range, that 40 to 50% ejection fraction. And in the green, we have preserved ejection fraction. Again, that female cohort, much more likely to be HFpEF overarchingly. From an etiologic perspective, we see that ischemic causes are a substantial amount, about 50% of ischemic causes of HFrEF, in males is from an ischemic etiology. So it's going to be even more important when we're talking about testing. When we think about a female perspective, if somebody has a preserved ejection fraction, ischemic's a little bit less likely. And so kind of, again, that pretest probability in how we think of what we should be doing overarchingly. So here are the etiologic causes. And I think of all my diagnosis and what I'm doing in testing with the understanding of what's actually causing the disease process as a whole. So what do I do when somebody comes into clinic? My first thing is a strong history. I'm asking about past medical history that will make sense to have caused heart failure. Are they an active smoker? Have they been smoking for the rest of their life? Do they have FH? Do they have very high lipids? What's their family history? Are they having active chest pain? Do they have any red flags? And I'm an amyloid doctor, so I have to bring this up. Do they have carpal tunnel syndrome, spinal stenosis, things that you should be thinking about, amyloidosis or a different type, for the underlying cause? Have they had a lot of infections at high risk for myocarditis? Palpitations, are they, saying that every third beat I'm feeling a palpitation? Maybe that's the cause of their heart failure. And as we know, pregnancy can cause heart failure as a risk factor for it. And so asking about that, which I think we don't tend to in adult medicine as much as we should. Did you have hypertension during pregnancy? How many pregnancies have you had? Was it complicated? Did you have heart failure after? So really making sure we take a good pregnancy history, which is something we're working on as a system. The second thing, and the most common after, you clinically suspect it and you have validated based on your exam or naturated peptides is really the echocardiogram. So what are we looking for? We're talking about two things. The first is, what are we going to do to treat this person, which an echocardiogram will help guide you. But we're also talking about etiology. Let's look at the valves. Let's look for wall motion abnormalities, gives you a sense of, was there an ischemic event before? Let's think about that infiltrative type of patient I mentioned before. Is there anything that we can find overarchingly? What is their filling pressure, left atrial pressure, IVC, right atrial pressure? And then is there any sense that there's a pericardial disease at play, all of which can come from the echocardiogram? ECG on every patient, absolutely important. So it gives insight into etiology as well as treatment, potentially, with CRTs and some other things that we can do. And so make sure in any patient that we have an ECG. And then from a lab standpoint, so CMB, CBC, iron studies, TSH, HIV, hepatitis, and lipids are a good starting standpoint. And so we can find some of these etiologic causes with abnormalities in this, with hemochromatosis, infectious etiologies overarchingly. So some more rare, but really can be helpful, and you want to make sure that you didn't miss this. Particularly, let's say it's hyperthyroidism, and we can turn that around and fix their heart without having to go down a steep route. The extras. Okay, if somebody's complaining about palpitation, extended rhythm monitoring is key. If they are 42 years old and they have 3 people in their family who've had heart failure as well, genetic testing should be kind of on the top of mind. Do they have an autoimmune disease? Do I need to be thinking about screening for autoimmune disease? Anything in their story really fit with that, which we know has an overlap overarchingly with heart failure too. So let's go back to that echo. So etiologically, so we're thinking from an ischemic evaluation standpoint, who needs to be sent for it? So in our world, in our practice, anybody with a below normal ejection fraction will get some type of ischemic testing. And really a critical piece, as we saw, 50% of particularly low EF in a male population is due to ischemic disease. What do you choose? This is dependent on pretest probability and then practically what's available. And so what we're doing in Salt Lake is going to be different than what's available, at a small place. So take what you have available in the context of this conversation. So if there's high-risk features, if they're a smoker, typical anginal symptoms, diabetes, older age, we send in general to angiography. That's your most sensitive and specific marker for significant epicardial coronary disease, and gives you an answer very quickly. And then depending on what it looks like, you can actually at times intervene upon it or have that conversation with your surgeons down the road. Low to moderate risk patients, young, no risk factors, we're often talking about non-invasive testing. We really like stress cardiac MRI. Both it helps with an ischemic etiology, but also helps establish non-ischemic etiologies. So if it's available, it's something that I think you should consider. CTA coronary is excellent and many times is the equivalent of an invasive angiogram from a diagnostic standpoint. And then PET generally has good sensitivity specificity. We're really hesitant to use dobutamine stress echo, to use stress echoes as a whole, SPECTs, and certainly stress ECG is not adequate. These really start to lose their sensitivity and their specificity when particularly you have low ejection fraction, because you might already have wall motion abnormalities that are not related to anything that's going on, just underlying cardiomyopathy. So think about it. What is the risk? What is the pretest probability? And then how good is the test that I'm using and structured in that order? all in the context of what are you able to do? Are patients able to travel? Can they actually get a stress MRI, for example, et cetera? And so everything is in real practice, in real life, is what you have availability for. For HFpEF patients or preserved ejection fraction patients, testing for coronary disease, if moderate to high test probability, is pretty common given comorbidities that are older patients, et cetera. So we oftentimes do ischemic testing, but again, it's a little bit less important, I think, than your low EF patients. And again, depending on the comorbidities in the context. So I've mentioned ejection fraction a couple times. So what are we using for ejection fraction? Less than 40 is HFrEF, 41 to 49, mid-range, preserved above 50, and then this new concept or improved ejection fraction where you started low, you've seen a 10-point increase, and you're consistently above 40%. So we use this in our notes, in our context, and in kind of our decisions on what medications to use based on this ejection fraction schema. There's pros and cons to this, probably outside of the context of this conversation, but in our guidelines and how we think right now, that's what we're using. So just very briefly, why does this all matter? GDMT, or guideline-directed medical therapy for reduced ejection fraction, has a profound reduction in mortality. A cumulative relative risk reduction of 75-ish%, an absolute risk reduction of 25%, a number needed to treat that you don't see elsewhere in medicine. And so why is this important? You see these numbers on the right. The second piece is mortality and low ejection fraction heart failure is worse than most cancers. An admitted patient has a 50% mortality at 2 years. How slow or how long it takes to get people on these 4 pillars of medications dictates their likelihood of recovery and being alive. So really important in starting early, not a 6-month, 1 year down the road type of thing. We bring people in every week or every other week to get them on all 4 pillars at their optimal dosages. Here's just a general schema about how these medications work across the ejection fraction spectrum. And we see that they have a higher relative efficacy at lower ejection fractions. And then when you get towards the upper end and preserved ejection fraction, less efficacy. More coming down the road as far as these therapies, and you'll have another session on it. But just to give a kind of a introduction overarchingly. So how does this play into clinic? Somebody comes in, they're referred to us for new onset heart failure. What am I writing in my clinic note? So I'm writing, okay, this is a 45-year-old patient. They have heart failure with reduced ejection fraction. I have the ejection fraction there, what modality, what was the time period. They're non-ischemic based on a left heart cath that was in X year. And then I really try to pinpoint etiology. So I don't leave it at HFrEF, I don't leave it at HFpEF. I try to say, what is the underlying cause of what's going on? And so this patient happens to have a TTN mutation, a type mutation. So I say they had myocarditis and an underlying genetic abnormality. And so this one statement or this 2 sentences, whatever it is, tells the next provider who's taking care of this patient almost everything they need to know in a very short period of time. So I'd encourage you taking on a similar type of idea, everyone does it a little bit differently, to really kind of encapsulate the information in a short kind of statement, and everyone knows where they need to go. So with that, I'll just make a quick plug for who needs to be advanced or referred for advanced care quickly. I think this is a nice mnemonic. I need help. If you're on inotropes, you have class 4 symptoms, your kidneys are getting worse, your ejection fraction is very low, you're getting shocks, you keep coming to the hospital, escalating doses of diuretics, very low blood pressure, and intolerance or having to withdraw guideline-directed medical therapy, all should make you think, okay, this patient might need to go to Seattle or Portland or wherever to talk about things like heart transplant or VAD, et cetera. So see these people and refer them early if possible. I'll turn it back over to you guys.
Well, thanks so much, Spencer. What a nice synopsis of an approach to diagnostic workup, and thanks for touching on GDMT as well. That's really a goal of what we're hoping to do with this whole series is to improve the number of patients who are getting onto optimal guideline-directed medical therapy. So please raise your hand if you have a question for Spencer, or put it in the chat. And while you do that, I'm going to go ahead and start things off. So talk about ischemic workup a little bit more. In some patients, there's a extremely low pretest probability. And I guess the question ultimately is, how much does it matter for the long-term management of that patient? If you could touch on both of those questions.
I think it's a really good point, right? And somebody comes to us and it's a 22-year-old and they've had four family members with heart failure and they have a known genetic abnormality. The likelihood that this is an ischemic etiology is very, very low. When I'm thinking of from a 10,000-foot view and I'm thinking of, okay, advanced therapies and these things, we won't transplant somebody without a left heart cath or some equivalent ischemic etiology testing that's adequate. And so, I really think it is important to make sure you're not missing something because it changes so much on what you do down the road. Now, I think the way we test is different. And I think that what we can accept as a result of, okay, this is a non-ischemic cardiomyopathy, is different in a high-risk patient versus a low-risk patient. But I'm very, very hesitant to not have some understanding. We just, for context, we're doing a heart transplant or, in a patient who was 44, they'd been referred to us from another center, low likelihood non-ischemic patient, per report, and never had a left heart catheterization. We get in there and they actually had on exam during a heart transplant 90% left main lesion. And so this
Wow.
is a person we maybe didn't have to transplant with low pretest probability.
Yeah.
So it's there.
Great. Okay, we have a question from Kelly. Specific threshold for frequency of ventricular ectopy as a cause of HFrEF. Great question.
And so anything that's a continuous variable, we really try not to dichotomize. And
Hmm.
so the higher the PVC burden is, we know that it has a higher risk of causing, a rhythmic cardiomyopathy. And so where does it start? At the very low end, 6%, I've heard can cause a small number of people to have a cardiomyopathy. 30% is substantially higher. And as you can imagine, where you are, kind of in between the two increases it. And so I won't give you a 16% or 15% on a heart monitor, but certainly the higher it is, the more likely. And somewhere between that 10 and 20 is when percent burden, if you will, over 24 hours when you start getting nervous that, hey, this is truly a potential etiology.
Can you talk a little bit more about how you use CMR for non-ischemic cardiomyopathy, and in particular, what diagnoses are you looking for, and how good is CMR to get those?
Yeah, so CMAR is excellent from a sensitivity standpoint for ruling out ischemic cardiomyopathy, 98% on a recent study published a couple of weeks ago. Specificity is still pretty good in the 90% range from an ischemic. So, outside of that, what we're thinking about, what are we missing, particularly in these elderly patients who have an overlap of disease process? Amyloid is 10% of HFpEF population. In your people that you're sending for TAVR, 15% of those people have HFpEF. If you're low flow, low gradient TAVR patient, 30% of those people have amyloidosis. And so it's a really nice way to look for infiltrative diseases, sarcoidosis, amyloidosis, to look for hypertrophic cardiomyopathy. And then also you can understand some of the non-ischemics based on the gadolinium pattern. So there are specific patterns with different mutations that give us a sense. And then we're neglecting the right ventricle as we do at too much, unfortunately, but it gives us good insight in what's happening to the right ventricle, ARVC, or arrhythmogenic cardiomyopathy, as we call it now. And so helpful across that space.
There are other questions? You
Yeah,
might.
so
Oh yeah,
what
go
do you
ahead,
think
Brian.
the payers to actually agree to cover for CMRI, and when are they actually going to say, yeah, you can have it? What clinical scenarios are they covering?
Yeah, and so maybe I'll bring it back, right? So from a payer perspective, a cardiac MRI stress versus an invasive angiogram from a total cost to the payer is remarkably different. And so in somebody who has a clinical syndrome of congestive heart failure, and that's what you're coding as your diagnosis, we don't have much pushback on the stress cardiac MRIs given that other modalities are actually quite more expensive as a whole, and in our guidelines, kind of an ischemic testing is considered very appropriate. So we don't have much pushback, for that ischemic etiology.
Okay, and then when I look at order options, I see like a MRI cardiac for velocity flow mapping, MRI heart function without contrast, MRI heart function with and without contrast. What is it you're ordering?
And so, this is dependent on each institution, unfortunately, about what you actually put as your order, but there should be an option for stress cardiac MRI. And that's specifically what I'm referring to today. And so our order is stress MRI. Chris, I don't know what yours is in your system or how you differentiate.
Yeah, we don't actually do a lot of stress MR. So we're actually ordering CMR more for someone who's had an ischemic workup otherwise, excuse me, and is a non-ischemic. So we're looking for those etiologies, and we order it with and without contrast for cardiomyopathy, essentially.
So multiple different options, and to your point, the way I deal with it is at the end of the day, there is a cardiologist who is protocolizing it, and so I really encourage you guys to actually put what you're looking for in the description, as opposed to clicking one of the boxes, say rule out ischemic. I actually comment, right? This is I just put my assessment in there. It actually really helps the imagers protocolize the study appropriately.
Yeah, and in some institutions, it's not a cardiologist, it's a radiologist, but either way, it's important to put what you're looking for exactly.
And then maybe just a brief comment on that. And where are the situations where we order the wrong test that can happen? Particularly if you're looking for hemochromatosis, it's a prospective. You actually have to change the protocol to get T2 star. You're kind of getting into the weeds on MRI, but that's where it's really important to have your clinical concern, in the description.
Okay, because we can get CCTA here pretty readily, but I haven't seen. But I don't think I've seen any stress cardiac MRs here.
And we love CTA. We use a lot of it for ischemic rule outs if for whatever reason somebody can't go to the cath lab or it's kind of a moderate risk. We use that a lot. In my patients that I think it's a non-ischemic and I think there's something else going on, but I still want to rule out, that's where I love MRI because you get, a lot of things, a lot of bang for the buck. But CTA is excellent as well.
Lindsay, remind me, we're going to 5 after? Or
Yes, we have some flexibility. That's a couple more questions is great.
any other questions?
Looks like Nathan, you're raising your hand.
Yeah, I just had a question about some of these traditional modalities that we use for ischemic workups that you mentioned have poorer sensitivity and specificity. SPECT, certainly stress EKG. Is that specific to a population with heart failure, or should we be using these modalities less for ischemic workups overall?
I think it's a great question, and I have to be careful who I say this in front of. I'm in my office. Who's next door to me? I don't know. But from an institutional perspective, we're moving away, from those traditional modalities. Certainly, there are specific circumstances that require them for a variety of reasons. But you look at the sensitivity, specificity of PET as compared to a MIBI or something like that, it's dramatically different. You get more information, but it's significantly better. Stress echoes, depending on what you're looking at, can be very helpful from a functional understanding of what's happening, in the myocardium. And so we still think there's utility or role for them. And as a screening test, many of these things, are reasonable to do in clinic outside of the heart failure space, for somebody who's coming in, with chest pain that doesn't quite make sense. Where are the situations where you would, still use SPECT, particularly if you don't have PET available, would be something like, okay, a pre-renal transplant patient who they won't take, unless you have some sort of, or, pre-op testing, kind of overarchingly. So I think there's a role for a lot of them. If you really want a good answer, you have to be thoughtful about the sensitivity, specificity, which unfortunately just aren't great with some of the more traditional modalities.
Other questions? I have plenty for you, Spencer. Can you talk about tachycardia-mediated LV dysfunction that might show up if someone's presenting with new atrial fibrillation, for example? What is your approach to that patient? Do they need a full workup for cardiomyopathy, or do you kind of control their tachycardia or their fib rates and then see what happens down the road?
I think the average person that comes in with that has comorbidities that increase their risk for other things, right? So it doesn't tend to be, somebody who's young and without comorbidity. Certainly, if that was the case, then, we might take a different approach. But let's say it's a 60-year-old who had some smoking history, we would do a full evaluation. This is an aside, from a programmatic standpoint, but the EP group won't see them without an ischemic evaluation. I'm not saying that's appropriate, but that's how it's done here, interestingly. So that certainly dictates some of it. But let's say it's a 35-year-old athlete who has AFib and they're going 160, 170, and it clearly correlates to the timing. We might try to control their rhythm with an ablation kind of strategy or a medication strategy, and then repeat and see where things go. And the same with something like sepsis-induced cardiomyopathy, which wasn't the question you asked, but somebody who turned around quickly, had a bacterial kind of infection, had a low EF transiently, and then by the end of the hospitalization came up. Just to go briefly back to the exercise stress question, one of the questions is, what is the best prognostic marker of any of the tests we're talked about? It's really how far they can walk on the treadmill. And so Ben Levine would be mad at me if I didn't say that. So how far somebody goes on the treadmill is probably more prognostic than anything else that we're talking about here when you're thinking about stress modalities. So it really depends on what you're using the test for, just to give that a more complete answer.